Okay, so neuroanesthesia. Yes, Dr. Anand, do you want to ask anything? Your hand is raised. Do you want to ask anything?
No, sir.
Your hand was raised. Just a second, guys. Actually, these windows open and then you have to close each of them. Okay, so actually, my screen is visible and I am audible to you. Okay, so actually, neuro anesthesia, usually it will be related to some craniotomy for tumor. This will be one category of patients. You will be, then there will be a trauma, like with polytrauma, as a part of polytrauma, or isolated head injury. Okay, and isolated spine injury. Whenever there is head injury, you have to consider spine injury until unless it is ruled out radiologically and clinically. Okay, this is another thing. Then you may have a patient with either brain tumor or any pathology in which there is raised ICP. Okay, and then there is some other surgery under non neuroanesthesia, non neurosurgery related thing. Okay, and there is another category which in which there is neuro interventional radiology. Okay, this is another thing, and there will be another category which patient will stroke. Okay, patient is stroke because of either ischemia or hemorrhage. Okay, for ischemia, after occurrence of ischemia or stroke or TIA. Okay, and this patient is undergoing carotid and arterectomy. Okay, and there will be another thing which you should be knowing, that any surgery or anything in which there are chances of neurological insult, like any patient with the prolonged hypoxia, okay, or like cabbage in which there is pump circulation, okay, or there is cardiac arrest. Following that, there is neurological insult, cardiac arrest, okay. Even in carotid and arterectomy surgery, following that, there is insult. Okay, so this is just an example of what you should be knowing about neuroanesthesia. Okay, so in the brain, there is one is blood, one is this one CSF, and third is the brain tissue. Okay, and this is in a closed skull, which cannot open further. Okay, so there is a basic which is called as Monroe Doctrine. The statement is that there are three things. So if any of pressure or volume increase, so it should be compensated by the other three. Like I will write it here again: brain, blood, and CSF. Okay, so if there is increased CSF production, it should be compensated by blood flow. Or if there is brain edema, the cells are swollen, so it should be compensated by either of them. If it does not occur, then the pressure inside the cavity will increase. Okay, so this is the main concept of all neuroanesthesia. Whatever you are doing, either it is a neurosurgery or it is any trauma. Okay, so your main focus will be revolving around this thing. Okay, Monroe, Kelly, Doctrine, that it has got three things. And if there is anything in which there is brain edema, so you have to manage it. Otherwise, the ICP will increase. Okay, so when ICP will increase, it will become a vicious cycle. So that is the main principle of neuroanesthesia. Let me show you. I actually opened some of yes, that's what I was telling you. Okay, so skull is a rigid structure, and Monroe Kelly Doctrine says that it is brain, CSF, and blood. Okay. So then there is a relationship between volume and pressure. So when volume is increased, there is at some time up till some time there is compensation, and when this compensation is exhausted, then you see the pressure is increasing. Okay, initially there will be focal ischemia. Focal ischemia means ischemia at one place, and then if it is not treated, then it will lead to global ischemia. So this is how you can understand, and this will be depending on the ICP. Normal ICP is around 5 to 10, and if it is increasing gradually, it will lead to 20 to 45, and the numbers will be different in different books, but you should understand the concept. Okay, that if it is initially, there will be focal ischemia, and if it is not treated, it will go to global ischemia. Okay, this book is Physics, Pharmacology, and Physiology for Anesthetist. It is there in the books folder. Then you go to Physics and Pharmacology, Physics equipment books, and you will find this book. Okay, brain compliance. Okay, this is what I've explained to you. We will come back to it. ICP waveform. We will come back to. Let me to tell you some other concepts before we come here. Okay, so the most important thing is cerebral blood flow. Okay, and usually it is 50 ml per 100 gram of brain tissue per minute, and usually it is around 750 mils per minute. 750 ml per minute. So just like isolated question, how much is the blood flow to the kidneys? Anyone, please? How much is blood?
25%. 25% of the cardiac output.
Tell in the number, around 1200 mils.
Yes.
And to heart?
Again, 55.
Again 1000 to 1200 ml per minute. And
Yes.
brain? Around 750 ml per minute. Okay, so this is how you can just revise your concepts. Okay, so then another important concept with reference to cerebral blood flow is the cerebral perfusion pressure. Okay, normally actually ICP and CVP, both of them are minor, so mean arterial pressure is determining it. But if either of them is increasing, in some books you will find it either of them. In some book they will add it. There are different concepts and written in book, but remember one thing, that if usually they are negligible, so it does not have a very significant effect. But in case of any pathology, when it is raising, then it will become significant. Okay, so then another concept of autoregulation. So can you tell me which organs in the body have autoregulation, or everything in the body has autoregulation? Yes, Usman.
That's the not this is.
Yes, sir.
Just
The
a second,
the kidneys
Usman,
have
let
auto-regulation.
just a second. I just you keep hold on Dr. Anand and saying something, which the
Okay,
thing
okay.
which miss. Just yes, Dr. Anand, what we were saying?
That's the not this is.
Unfortunately, your voice is breaking. Can you speak loudly?
Screen not visualized, sir.
I'm sorry.
So screen not visualized.
I am unfortunately I cannot understand what you are saying.
Sir, I think he's saying screen is not
Screen is
displaying, I
not
think.
visible. There is some problem with your mobile. Just check it out. Everyone else can see the screen. Am I right? You can see Usman screen.
Yes.
Yes, I can see.
Okay, so now Dr. Anand, I think you just check your mobile setting. It is visible to everyone. Yes, Usman, just for a revision, which organs in our body has auto-regulation?
Sir, the kidneys have
Kidneys.
autoregulation.
So the pressure here is 80 to 180. Okay, the limit.
Brain,
So that's
brain.
why, yes, that's why if there is hypotension, the kidneys goes early. So there is urine output goes. Okay. So then brain
Heart.
Brain is 60 to 160 usually. Okay. Heart has autoregulation with local metabolites.
Local metabolites, yes.
Okay. But it has autoregulation. What about liver?
Liver, yes, the Haber system.
What's that one?
Like if hepatic, if portal vein has got low blood flow, the hepatic arteries will compensate, and vice versa.
Actually, as far as I know, the portal pressure is cannot be autoregulated.
Yes, sir. There is a Haber system. I have read somewhere. Haber system is there in liver.
Haber. Okay. If you can share, because in my concept, liver cannot have autoregulation.
Yes, it has a small autoregulation, you can say.
Okay. Okay. So that anyways, so this was just a little revision of the concept. So autoregulable ability of an organ to regulate its blood flow despite changes in perfusion pressure. Okay, so this graph is the most important thing which you should have a concept, that this is ml per 100 gram per minute. As we told that it is around 50 ml per 100 gram per minute, and it is maintained. You see the pressure are increasing or decreasing between 60 to 160, and the blood flow is the same. Am I right? So when this pressure is increased, then blood flow is increased, or if it is going below, then the blood flow is decreased. Okay. So this is the concept you should be knowing. And that is the concept what happens in hypertension, that this curve is shift to the right. So instead of hypoxia at 60, it may be occurring at 80. Okay. So in this patient, if there is hypotension or mean arterial pressure is decreased, there may be ischemia, because they are in habit of high pressures. Okay. So that is the concept what we say, that in chronic hypertension, the cerebral autoregulation curve is shifted to the right. That is the concept which we are discussing. So this, just have a look at it. Very simple to understand. And actually this book is wonderful book for understanding the graphs, because it is to the point and you can understand these graphs. Okay. So now come to the most important thing, that what factors affect the cerebral blood flow. Okay. So if we just think, what are the different factors? PCO2, PO2, temperature. What else?
ICP.
Viscosity, ICP, cerebral perfusion pressure. Okay. So among them, the most important is PCO2. It has a very regular gradual increase or decrease in CO2, which has effect. PO2 up till a certain pressure, it does not affect much, but after 60 millimeter of mercury decrease in PO2 less than 60, then there is increase in cerebral blood flow. Temperature, it has linear, I think, also increase in temperature, increase in cerebral blood flow. And viscosity, if the blood is too much viscous, then the flow is decreased. Okay. And ICP and cerebral perfusion pressure also important determinant. Okay. Just a second. Okay. So you see, that's what actually this is written in kPa. So 1 kPa is equal to 7.5 millimeter of mercury. So for example, if it is written 10, it means 75. If it is written 50, so that's like you can multiply these numbers, because in British books, Usman may know about it. Do you know why I would say that we should also use kPa? What is the reason of not using millimeter of mercury rather than we should use kPa? What is the reason for it? A very simple question. Because this is SI unit.
SI unit.
Very good. This is SI unit. Okay. So this is SI unit. So kPa is SI unit. So like increase in CO2, increase in cerebral blood flow up till at a certain limit, then it becomes, there is a stasis. And similarly, if there is chronic hypercapnia, there is some autoregulation. There is some stasis. So after that, its effect is gradually decreased. That's what occurring in chronic hypercapnia. Okay.
So
And
what would be the PCO2 required for central drive in COPD patient?
this is not
What
related.
range?
This is not related question here. CO2, that is something else. That is for respiration. That is not for cerebral blood flow. That CO2
Ji.
drive is for respiratory center, not for cerebral. So your question is not
Yes,
valid
sir.
here. Okay. That is, the concept is that CO2 increase, CO2 is stimulating the respiratory center. That is increase, that limit is increase in COPD patient. That's not, we are discussing at the moment related to cerebral blood flow. Okay. Okay. So as I told you about hypoxia, that up to a certain level, up to 60, as I told you, in some books you will find 50, in some books you will find 60. So around 50 to 60. And here they have written at 7.5 kPa, I think around 8 kPa. So there is not much increase in cerebral blood flow. That cerebral blood flow remains normal. And then after that, it suddenly increases. When cerebral blood flow increase, actually ICP is increasing. It's a last ditch effort to save the brain. There is hypoxia, 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 hypoxia. And after that, cerebral blood flow is increasing. But actually, it is it's becoming a vicious cycle. Okay. Okay, this is another concept which you should be using, that how much oxygen is consumed by the brain. Usually brain can use other than glucose and oxygen. They are using ketone bodies as well. Okay. But that is separate. This number can be asked in MCQs. It is 3.3 ml per 100 gram per minute. Okay. So similarly as cerebral blood flow, because why it is important that whenever increase requirement, increase blood flow and increase requirement are parallel. Okay. This is directly proportional. Okay. So you have this straight, as much as cerebral metabolic rate is increasing, as much as cerebral blood flow is increasing. So they are together, going together. That's why when there is ischemia, that's why we use this oxygen, this one decrease controlled hypothermia, or we do this barbiturate coma, because our purpose is to decrease the oxygen requirement and decrease the cerebral metabolic rate. So that is a concept. The phenomena whereby the perfusion to an area of brain is matched to the metabolic rate of that area. Okay. This may occur locally or globally. That's what I told you. Okay. So temperature. So temperature also has effect on cerebral metabolic rate. So when there is hypothermia, metabolic rate is decreased. So that is a concept which we use in targeted temperature control, which we do. Okay. Okay. So in this graph, they are telling all what you should be knowing in the anesthesia, because all the inhalational agents, they increase cerebral blood flow, they increase cerebral metabolic rate. Okay. And these barbiturates, they not only decrease cerebral blood flow significantly and also decrease cerebral metabolic rate. Okay. So among them, the most is thiopentone. That the concept, I will tell you a few concepts about it, or we can discuss it right now. One concept is Robin Hood. What is Robin Hood phenomena? What is cerebral steal? Can anyone tell? And what is
Ischemic areas in the brain, the feeding vessels can't accommodate the change in flow.
okay?
That's why it may convert the blood from those ischemic areas to the well-perfused area.
Yes, like Robin Hood used to steal the rich people and give it to the poor people.
Poor.
So that is the Robin Hood phenomena, that instead of because usually what happens, there is an effect, Coanda effect. Coanda effect is that if blood is going and there is a vessel is diameter, this diameter is more and this diameter is very narrow, so blood will tend to go here rather than here. Okay, so this is cerebral steal.
Yes.
The area where there is decrease in cerebral blood flow, it is actually increasing because of Coanda effect. Okay, and some of the anesthetic agents like Robin Hood phenomena is with this one barbiturates. Okay, and also barbiturates has luxury perfusion. If you increased your salary, just a second, if you increase your salary and decrease your expenditure, so your saving will increase.
I think this is with the inhalational anesthetic, sir.
Luxury perfusion?
Looks.
Luxury
Yes.
perfusion is with the isoflurane as well.
Yeah.
Luxury, but actually, if you see this graph, okay, if you see this
Because
graph,
I think that
yes, I
barbiturate
understand.
will not increase the blood.
I agree to your point. Yes, I understand. You are yes. You thanks for correction. Isoflurane
Welcome.
is not only in decreasing. Actually, the thing is that barbiturate also do it, but among the inhalational agents, the best one is isoflurane, because it does not increase cerebral metabolic rate as others do, like nitrous oxide or even this halothane. I don't agree with this alignment here. Maybe all others, they slightly increase cerebral metabolic rate, or no? Yes, Muhammad.
Yes, sir.
Yes, you like just correct me that you think that all inhalational agents decrease cerebral metabolic rate.
It decrease, yes, cerebral metabolic rate and increase the blood flow to those organs. This is luxury perfusion, except
Yes.
for nitrous oxide.
Nitrous oxide, because my concept, you are absolutely right, but my concept is that this effect is only with isoflurane, and rest of them, they don't have that much effect. This is my concept. That's why we use isoflurane. And this is also depending on the MAC. If you are giving less than 1 MAC, then this effect will occur. But if
if more than 1 MAC,
yes, more than 1 MAC, then this effect is not there. This is what I understand. I think any one of you can recheck about it, but that I will repeat that if cerebral blood flow is increased, but cerebral metabolic rate is not that much increased, then it is creating a luxury perfusion, that there is more blood flow than required. Okay, and this is occurring more with isoflurane, and it is also related to the MAC which you are giving. If you are giving more MAC, there is more cerebral vasodilatation and there is too much increase in cerebral blood flow. Okay, without any effect, much significant effect on metabolic rate, because you want the metabolic rate to decrease. Why? so that the ischemic area does not become more ischemic. Because if there is too much metabolism going on, too much oxygen requirement, so that will create more neurological insult, more neuronal damage. Okay, I hope I have made everyone understood. I repeat again, cerebral blood flow and cerebral metabolic rate are the one which will be determining not only the extent of increase in ICP or extent of neurological problems. If there was ischemia, now you want to decrease the cerebral metabolic rate. So you want something which is not only decreasing the cerebral blood flow, also decrease the cerebral metabolic rate. So that's why barbiturate is the best one among them. Among, if you are using inhalational agents up to 1 mg, there is less effect and there is increase in cerebral blood flow without much increase in cerebral metabolic rate. Okay, and the best among them is isoflurane. But if you are increasing the MAC and you are giving too much isoflurane, then the blood flow effect is increasing and increasing. So that is increasing the ICP. When there is increase in ICPs, there is decrease in cerebral perfusion pressure. So then ischemia will be increased. So that is a concept. I think I have just tried to explain it to you. Okay. All these except sevoflurane cause dose-dependent vasodilatation, which results in an increase in cerebral blood flow. They also decrease cerebral metabolic rate, uncoupling the flow metabolism relationship. When concentration of 1.5 mg reached, then cerebral autoregulation abolished. Sevoflurane has minimum vasodilatory effect until a concentration. That's what I was telling. I think that's the same thing. And actually, in different books, you will find two of them good, either sevoflurane or isoflurane. Okay. So there in different books, you will find a slight different result. In some books, you will find isoflurane, and some books you will find sevoflurane. Okay. Intravenous anesthetic agent, with the exception of ketamine, decreases both cerebral metabolic rate and cerebral blood flow, and maintain the coupling between the two. Ketamine is unusual in that it increases both, but increases cerebral blood flow more, and it is often avoided in patient with. Again, this role of ketamine is dose dependent. If you are using it in a very low dose as analgesic, so it is blunting the stress response. So actually it can help. But if you are using it in slightly higher dose, then that effect will be there, that it will be increasing cerebral blood flow and cerebral metabolic rate. Okay. Opioids have less effect. Okay. So actually you should be knowing about this chart, and actually this is also coming in MCQs, and they can ask you about CSF production. So we discussed the effects of blood flow, and this is the production. It is around 500 ml per day, okay, or 0.35 ml per minute. Total volume of CSF is around 150. So there is constant production and constant drainage. So this is the chart which should be produced by the choroid plexus of lateral ventricle. Through foramen of Monroe, it goes to third ventricle. Through Sylvian duct, it goes to fourth ventricle. And through foramen magendi and foramen Leschka, it goes to spinal canal and absorbed by the arachnoid villi in venous sinuses. This is the cycle. And if there is any obstruction, the CSF drainage, if it is not drained and production is going on, so the ICP will increase. The same thing which we discussed about blood flow, the similar things are here. And actually, it's not mentioned here. There are specific points where there will be obstruction and the ICP will be increases. Okay. So these are a few things about the basic concepts. Just a second. Yes. The same thing which we discussed. The basic concept. Global flow is there like this: 50 ml per 100 gram. White matter 20 ml per 100 gram, and gray matter 70 ml, and global it is 50 ml. Okay. Resting oxygen consumption is 50 ml per minute, 20% of the total body oxygen requirement. Usually it is around 250 ml per minute oxygen requirement in the body, 250 ml per minute. Okay. So regional cerebral blood flow varies depending on metabolic rates of local areas of brain. Okay. Cerebral blood flow exhibit autoregulation, as I told you. Cerebral perfusion pressure you have to maintain around 70 to 80. Okay. And cerebral blood flow, myogenic theory versus local local metabolites. Cerebral blood flow is autoregulated between, you see in some books you will find 50 to 150, in some book you will find 60 to 160. So it depends, and it is shifted to the right. Myogenic theory, a change in perfusion pressure results in myogenic response in the cerebral vascular smooth muscle in order to maintain constant cerebral blood flow. For example, a hypertensive response during exercise with an increase in mean arterial pressure results in cerebral vasoconstriction, thus keeping cerebral blood flow constant. Conversely, a fall in mean arterial pressure will result in cerebral vascular smooth muscle relaxation, causing vasodilating. Like if there is a increase in pressure, it is vasoconstricting. If it is decrease in pressure, this is myogenic theory. The other is the release of the metabolites like potassium, hydrogen, adenosine, nitric oxide, which are causing vasodilatation. So actually both theories are there. We have discussed actually these things, PaO2, PaCO2 in cerebral blood flow. This is about PO2, that if it is decreasing, then suddenly it increase, and that is about cerebral blood flow. As this one about CO2, we have read about it. Volatile all increase cerebral blood flow and reduce cerebral metabolic oxygen requirements, thus uncoupling cerebral blood flow from cerebral metabolic rate, that is called as luxury perfusion. And I just said that up to certain MAC. If it is MAC is increased, then this uncoupling this autoregulation is finished. Okay. Nitrous oxide increase cerebral blood flow and increase cerebral metabolic rate. Neuromuscular blocking agents does not affect cerebral blood flow. Induction agent, with exception of ketamine, all decrease cerebral metabolic rate, cerebral blood flow, and ICP. Okay. 1 degree centigrade increase in temperature, increase or decrease effect by 5 to, in some books you will find 5%, in some books you will find 7%, like it is 5 to 7%. Okay, what effect does brain injury have on cerebral blood flow? Brain injury can lead to loss of cerebral autoregulation in injury affected areas of brain, resulting in development of a pressure dependent perfusion. Like pressure, this autoregulation is lost. I will discuss. I'm just showing you this thing, and then we will discuss what happens in it. Okay. So okay. So as I told you that if this is the same Monroe doctrine we discussed, and CSF, if there is raised ICP because of hydrocephalus, if it is not draining, brain tumors or any injury resulting in edema or hematoma, whether it is subdural, subarachnoid, okay, so increase in blood. Okay, we have discussed that volume increase, then pressure increase. This is, we have seen it. Okay, fall in mean arterial pressure, fall in cerebral perfusion pressure, vasodilatation, increase cerebral blood volume. So it is a vicious cycle. Okay, when there is decrease in mean arterial pressure, fall in cerebral perfusion pressure. As a result, there is compensatory vasodilatation. When vasodilatation occurs, there is increased cerebral blood volume, and then at certain limit, yeah, that's what they have telling you. Okay, so if it is compensated for some time, and after that, the compensation is finished, and then pressure is increasing. Okay. Okay, vasoconstriction, rise in mean arterial pressure, rise in cerebral perfusion pressure, vasoconstriction decreased. This is what occurs. That's why we are using barbiturate and things like that. Okay. Okay, so now we will go towards the trauma patient. Okay, so when there is trauma, there is head injury. So some of the things which we should be knowing, how to do the airway management. This is one question. And because you have to consider spine injury unless it is ruled out by nexus criteria or Canadian C spine. You can read about it, but there usually this is that there is no other distracting pain. Okay, patient is not intoxicated, conscious level not comatized, and there is no neck tenderness, There may be one other thing as well. And there is in Canadian class, I think there is high impact and increasing age, things like that. Okay. So the basic thing which you have to remember, that in any head injury, you will consider spine injury, and you will do what you will do, it is called as MILS, manual inline stabilization. Okay. And you will have a collar, and you will avoid extension and lateral movements of neck, extension, flexion. You will not try, you will try to avoid any manipulation. Okay. So this is, so now this care of spine makes the airway in the traumatic patient challenging, because restriction of neck, then this trauma patient, usually they will be considered as full stomach. This is number two. The collar is making the laryngoscopy difficult. Patient is full stomach. And then another problem is related to ICP and cerebral perfusion pressures. Okay. So that
Lockjaw.
becomes, so that makes the airway management in head injury patient difficult. So how will you manage it? You will have to use the video laryngoscope, or glidoscope. Okay. And you have to blunt the sympathetic stress response with fentanyl or beta blocker or anything. You can take invasive blood pressure monitoring. Okay. So that you monitor the cerebral perfusion pressures. Okay. Mean arterial pressure will, and another thing, another important thing is that you have to zero, not at the, usually we zero the arterial blood pressure transducer at the level of heart, but here we have to zero at the level of external auditory meatus. So because it will slightly reflect the cerebral perfusion pressure. Okay. So you have to zero intra-arterial blood pressure slightly higher at the level of external auditory meatus. So this is the thing which you can do. And propofol or thiopentone, both of them you can use. Yes, another thing here is that patient may have fits or aspiration. Okay, so and another thing which I in case of polytrauma, patient is in hemorrhagic shock. Okay, and there is some involvement of thoracic injury. So that will actually further complicate the management of airway. So the basic principle you will have, what about suxamethonium versus rocuronium? Suxamethonium can increase ICP transiently.
Yes, sir.
Okay, so you have to consider risk versus benefit. If you have Sugammadex, then it is preferable to use rocuronium. Otherwise, risk versus benefit, because you have to maintain the airway. So you can use suxamethonium at the cost of transient increase, and you can titrate it. That's why you will be monitoring if it's possible. Before you can monitor ICP. Okay, ICP may be monitored by a number of ways, but you can monitor the ICP as well. So rapid sequence induction versus modified rapid sequence induction, you will be doing. Okay, so now your aim is to monitor CO2, monitor O2, monitor pH, monitor cerebral perfusion pressure. Okay, so you have to keep around 33 to 35 millimeter of mercury CO2. Okay, and of course you have to maintain more than 60 pH. Of course you don't want acidosis, and cerebral perfusion around 70 to 80 millimeter of mercury. This is called as, because primary brain injury is done already. You cannot prevent, but you have to prevent secondary brain injury. Okay. So for that, these things, you have to avoid the sympathetic stress response. Okay. And then like you will avoid ventilator patient stacking. Okay, because this will increase the airway pressure, and it will theoretically increase CVP, and it will increase ICP. Okay. Then another thing you have to do, you don't have to put tight bandage around the neck. Avoid tight bandage around neck. Okay, because it will again, because the blood vessels, the venous system in the coming from the brain is without any valves. So if you put tight, it will cause. Then another thing which you have to do is head up, 30-degree head up, to avoid venous congestion. Okay. So these are the basic things which you have to take care. And when you are shifting, will be very careful. Okay. Because from emergency, patient may be transferred to CT scan. And this question they ask. You have to, ideally, you have to maintain the airway before you transfer to CT scan. Okay. Because this patient might, from CT scan, whether it will go to ICU or whether it will go to OR. Why? If there is compression which is expanding hematoma with midline shift, okay, they will go to drain to OR. And if it is not like that, you will be taking the patient to monitoring in the ICU. So that is this is one shifting, or the shifting from one center, from primary center via ambulance to neurosurgical unit. Okay. So in that, again, all the care related to mills, related to resuscitative medication. Okay. Then careful movement of the patient. Then you should have vasoconstrictor, vasodilators. Okay. Oxygen, double the duration of transfer. Okay. And if it is air ambulance, for example, so there will be problems related to pressure changes, atmospheric pressure changes. Okay. And it will be related to not only ICP, oxygen, and if there is any like chest drains. Okay. So these are the things we should be considering. And mainly, and another thing is viscosity. Like you have to maintain hematocrit around 30 to 35. You don't need to overcorrect it, because the flow will be decreased from, and it will be from laminar to turbulent. You don't want turbulent flow. Okay. So you have to maintain the viscosity. Temperature, we have already discussed. We will avoid hyperthermia. Okay. Then there will be chances of, as I told you, that there will be, because if there is EEG monitoring, this will also tell you. And there may be, because of ischemia or because of electrolyte imbalance or because of hypoglycemia or because of raised ICP, there are chances of fits. Okay. So in these patients, in order to maintain everything, you will be avoiding the factors which can precipitate the fits, and you may be giving some phenytoin or magnesium or any anti-epileptic, like Keppra is one of them, levetiracetam, something, I don't know the pronunciation correctly. So we always use this trade name Keppra. Okay. So whenever these medications are there, you have to maintain the blood levels. Okay. And you have to anticipate. So you will preferably put bite block, because tube, and maybe you are using reinforced endotracheal tube, and you are making the patient quiet and calm by good sedation and muscle relaxation. Okay. You are avoiding any swings in blood pressure. You are avoiding hypothermia. You are avoiding hyperthermia. You are avoiding hypercarbia. You are avoiding acidosis. You are avoiding hypertension. You are avoiding hypoxia. So all these factors are for the prevention of secondary brain injury. Okay. Is it clear now? So that's what I was just telling you, whatever is written here. Yes, yes. So if all these fail, then you can consider about some this one furosemide or mannitol. Okay, this I forgot to tell you. So you will, if these all maneuvers, anesthetic maneuvers, positional maneuvers, medications, this, if it is all failing, then you can consider about furosemide or hypertonic saline or mannitol. Okay. So you will treat pyrexia.
And
Yes.
hyperventilation. And hyperventilate.
We have told that we have to maintain, we don't have to hyperventilate. We have to maintain the PCO2 around 33 to 35. If we hyperventilate, there will be cerebral vasoconstriction, which is equally bad. It's not concept of hyperventilation. It's concept of maintaining the PaCO2. Okay. What they have written? Maintain normocapnia and normoxia. Okay. Hypercapnia as well as hypocapnia, both are bad. So never use this word hyperventilation. You don't need hyperventilation. You need to maintain CO2. You don't let it high. You don't let it become high. Okay. So normoglycemia, avoid hypotonic. Yes, another thing which I have missed is the problems related to sodium imbalance. There are problems related to sodium. So a number of things can occur. Diabetes insipidus can occur. I will tell you, SIADH can occur, and cerebral salt wasting syndrome can occur. Diabetes insipidus is because of lack of ADH. Okay. This is because of increased ADH. Okay. And cerebral salt wasting syndrome, there are a number of factors, but actually there is hypovolemia plus hyponatremia.
BNF also released from the brain.
Yes. Can you tell some words about cerebral salt wasting syndrome? Because diabetic insipidus is because of either nephrogenic and or neurogenic. Central or neurogenic and nephrogenic. Okay. So neurogenic is that ADH is not released in adequate amount, and if nephrogenic, that ADH is there, but it is not acting, its effect is
resistant to ADH.
So a syndrome of inappropriates too much ADH, so it is extracting too much water. So there is hyponatremia. What happens in cerebral salt wasting syndrome? I don't remember. I cannot recall it. But
in
I know this.
salt syndrome, there is a loss of fluid as well as salt.
Yes, that's what I'm told. But what is the reason for it?
Is sir, because of the brain natriuretic factor that is released by the injured tissue, the damaged tissue of the brain. BNF, brain natriuretic peptide or factor.
Yes, so you have to monitor the serum electrolytes, you have to monitor the CBC, and you have to do the urinary examination. Okay, so in urinary examination, especially you are monitoring the sodium. Okay, so then and on these basis you will be diagnosing and managing the with hypertonic saline. Okay, and actually you have to do it slowly, because if What is the word for that one? I forgot the name. If you correct it fast, what is that? Central pontine myelinosis. Okay. Because of water coming out of the cells. Am I right, Usman? If corrected rapidly. Usually, I think it is 0.5 milliequivalent, 0.5 to 1 milliequivalent per day, per liter per day. Am I right? I'm bad in recalling the numbers. Please just recorrect it. But the basic thing is that you have to correct slowly. Okay. Do not administer hypotonic fluids like 5% dextrose, which will increase brain edema. Okay. CSF, we have discussed. Okay, blood-brain barrier. When there is a cerebral injury, there is this blood-brain barrier is lost. This is also coming in MCQs. You should be knowing about the composition, which is more, which is high. It is not only related to the head injury. Okay. Okay. So I think you have made some of the concept about cerebral's neuroanesthesia, because whatever we are doing in neuroanesthesia, for example, now we have a patient with the brain tumor and this patient is going for craniotomy. So believe me that these are the things which you should be noting. The only extra thing will be in brain tumor, you are using dexamethasone to reduce the ICP, which is not there in head injury. It is increasing the mortality, morbidity if you are using it in head injury. So dexamethasone is being used to reduce cerebral edema or increase ICP when you are dealing with a patient with brain tumor. Brain tumor usually are benign, but they are locally invasive and they usually don't have metastasis. Okay. But they are causing neurological problems. So you have to rule out any neurological deficit, any cranial nerve injury, a cranial nerve involvement preoperatively. And then this patient, according to the surgical outcome, may be monitored in HDU. There is not necessarily to keep the patient intubated. If the patient is remaining intubated, you have to maintain everything which we discussed. The same theory which I have told you. Only difference is in posterior fossa surgery, because posterior fossa surgery, there are concerns related to the sitting beach chair position. And what is the selling complication which you have to tell in neurosurgery? Of course, bleeding can occur, neurological deficit can occur post-operatively. Okay. What is the thing which you have to tell? Remember, first thing, what is that one? What is that complication in neuroanesthesia?
Embolism.
Air embolism. Okay. When air embolism occurs, what you have to do? Call for help, head down. Okay, irrigate the area, irrigate with normal saline, use bone wax, call for help and inform surgeon. Okay, inform surgeon. If you have a CVP, you will try to aspirate. Okay, the earliest recognition with end-tidal CO2 and end-tidal nitrogen. End-tidal nitrogen increase and end-tidal CO2 suddenly decrease. If you have T, this is the earliest detection. Okay, and it is even detecting small amount of air, even up to 0.5 to, but like very, I cannot, I'm again say that I'm very bad in recalling the numbers. So it is the earliest and sensitive. Okay, so with the help of T, with the help of CVP, end-tidal CO2, end-tidal nitrogen, irrigating the area, head side down, increasing the venous pressures, even compressing the abdomen, all these things you can do to increase the pressure so that the air is removed. Okay. Otherwise, if patient collapse, then the same thing, cardiac arrest algorithm, you have to, ACLS, you have to follow. Okay. But this is Again, the use of fluids and vasopressors, everything is the conventional management of any cardiac arrest or any hemodynamic collapse. Okay. But the thing you should be remembering that earliest detector is end-tidal CO2 decrease and end-tidal nitrogen and T. Okay. And CVP, you can aspirate. That's what about air embolism. Okay. And what are the concerns related to sitting or prone? Okay, prone position, all the problems related
Nerve
to
injuries.
bone, nerve injury, okay, and neck injury, okay. And there is physiological, if the abdomen is not free, there will be decrease in cardiac output, okay. There will be a problem with genitalia or breast in case of female, okay. And so you have to position very carefully, prone positioning, okay. We do intermittent prone, but the most important thing is that the proper positioning is very important. You can damage the you can dislodge. Now another question: if you happen to dislodge the tube ETT in prone position, what will you do? Yes, doctor.
Stop the surgeon, call for help.
Okay. Then what else?
Reposition.
Reposition. Is it easy to reposition? The brain is open and everything.
With the help.
Okay, so actually you will start bag mask ventilation.
Okay.
Okay, you will try to put LMA or iGel. Okay, but the most important thing you did not say, mask ventilation. Okay, even in the prone position, you can do the mask ventilation. Okay, so the next question, actually this question was asked in our FCI exam. And you are not able to ventilate the patient properly and the patient went into cardiac arrest. Now what will you do? You will start CPR from the back till the time you are able to. Okay, and actually this question was asked with reference to spine surgery. Okay, so in the spine surgery, you are starting CPR from the back, and if you are failing, then they can do the open cardiac massage. Okay, this is the last resort if nothing is going, because maybe it is not very easy to do the compression in the prone position. Okay, so because, and actually in spine surgery there is a special table with a hole in the center. This is a special table, so actually it's not easy to do change it very quickly. There are strappings are there, so the abdomen is there hanging here. Okay, so there is the head is there, so it is not easy to position the patient. So actually you have to start CPR in that position till the time you are able to transfer the patient on the trolley. Okay, and the thing which you have to tell that, because ABC, don't ever forget. So if the patient is not oxygenated, tube is dislodged, you will try to ventilate with the mask. Then second step, you will try to put iGel or LMA. iGel will be maybe able to pass, because it is difficult to do it, but you will try to do it. And what about there is another thing. What about fiber optic? Okay, you will try to arrange it, and if you are failing, you can. This is actually you have to. You don't have any clear-cut option. Okay, so you have to do it like that. Okay, that's why whenever you are doing any neurosurgery, the trolley should be around. Okay, and that's why this is very important to carefully place the tube. Okay, fix the tube so that it's not dislodged. Okay, so in brain tumor, I told you that there will be things like that. All craniotomies except for awake craniotomy. Okay, we will discuss awake craniotomy and subarachnoid hemorrhage in our next session. Okay, so it's not possible to do it one session. I will try to do it tonight at same time which I discussed yesterday. Any questions? Do you understand? Is it understandable? Because remember one thing, if you try to read the crap books, only cram the words, you will never be able to understand. If you have the concept, you can answer and you can understand anything. Yes, Dr. Nadeem.
Yeah. Is it better to avoid nitrous oxide and use the volatile with air?
Of course, actually, there are two group of people. One group of people is in favor of nitrous oxide, and one group of people who are not using. In majority of centers, actually, they don't have nitrous oxide, so they are using air. Okay, in Pakistan, because we don't have air supply, so we are using nitrous oxide, because 100% oxygen is never a good choice to use so our air is always there. In the exam, you can always say air. Okay, and if you have any doubt, nitrous oxide you will avoid, of course. Okay, but remember, nitrous oxide is excellent analgesic. Okay, so actually I am among the people who in favor of nitrous oxide. I love nitrous oxide. Okay, so thank you very much. So we will have the remaining part of neuroanesthesia. I hope you understand. Okay. Neurocephalus, yes, of course. You see, listen, Samir Rahman. The thing is that you in the exam, unless this is MCQ, even in MCQ, they always give a hint. Remember one thing. In the oral exam, it's very easy to defend. You will say that if you have any doubt, you will not use it. Nitrous oxide is not mandatory to give anesthesia, am I right? So if you have any doubt, not only pneumocephalus, in any patient where there is chancing of expanding, if any patient because the problem is that nitrous oxide is higher, can go in the closed cavity and increase it. So of course, pneumocephalus, you will never use it. Okay. So thank you very much. All of you are like I'm just trying to make all of you familiar so that you can use it. Actually, this is the channel and you can go to the playlist. Okay, and you will find, like, if you want to get benefit, you can just scroll through these playlists. Okay, and for the people who don't understand our native language, before I used to take it in our native language, but you see, go to the Neuro. Okay, oh, just a second. Okay, and you will find before I have discussed. So in last, I think 6, 7, rather more than 7, I think since December, all the discussions are in English. Okay, so majority of the discussions you will find in English. Some of them you will find, maybe I think this one is in our language. So it is better if you want to understand, you would listen to it, because some of the things I have discussed now, before I was not able to use I don't have this stillet and this facility. So I am trying to improve myself as well, because I'm not doing it for any interest. I don't have any financial or any motive other than to keep myself in touch with studies and make you understand and make you liberate all of you from books, especially manhus. Manhus is the word which will not understand. Manhus is in English the terrible Morgan, because it's a curse for all anesthesia residents. Okay, so read from articles, you will find. Just a second. Okay, I'm sorry, the screen was not sharing. So you see, this is the playlist, and you can find in the playlist, some of them are in our native language, but majority of the playlist is in is in English. Okay. So if you don't understand anything, you are welcome to ask anything, anytime. Okay. The name is Physics, Physiology, and Pharmacology for Anesthetist, Dr. Shearing. It is there in the link. Unfortunately, majority of people don't use the link. So that's why you are not aware of this thing. Let me show you. This is the link which I have. Okay. So in that there are the articles, tutorials arranged in the topic wise. Then there are books. This is FRC and mind maps. Topic wise question. If you want to understand what a topic has, I have made a number of topics like that. It's not perfect, but you will find a lot of data here. Okay. This is for Viva scenarios. You will go to the books, and then these are basic sciences books, review books, clinical science review books, ICU books, MCQs books, okay, OSCE books. Here in physics folder, you will find it, the book which I was showing to you. This is for all, if you want to understand any equipment, anything related to monitoring, this is the book for that. If you want to understand any basic concept, this is the book I was showing it to you. Okay, so this is an excellent and easy book. If you want to understand, you can just have a look here. These are the things which are basic sciences, but actually, till the time you like see, today we discuss about Coanda effect. Today we discuss about laminar turbulent flow in case of cerebral perfusion. So if you don't know this, how will you understand? Okay. So here, and these I will highly suggest you, even the first year residents, believe me, if you are able to understand this, how to study from these books, you can make them like a vision to how you should be approaching any case. See, you have a patient like this, and then how will you approach it? And you have to probe each and every word. 70-year-old, there will be concerns related to 71-year-old. Elective surgery, which was abdominal aortic aneurysm. So it is prone to have renal problems. It has prone to have neurological problems, spinal cord injury. Okay. And this patient can bleed. This patient can have hypertension or hypotension. This patient, because of problem in the heart, this patient will have arrhythmias. So you will just think logically, and you will understand each and everything. So I will highly suggest you to read these cases and probe each and every word, like aortic cross clamping. What are effects of aortic cross clamping and unclamping? Okay. Similarly, actually, because you people are in love with Morgan, so I cannot help. All these books are alike. You can start with any of the book, and then you can compare it with other. Okay. And these are SAQs books, and any exam, if you have any SAQs pattern, so you can target, and you don't need to read each and every line from that book. You can take the questions, you can think, you can even search the answer yourself, and then compare the answers. Okay. So actually, this is a new way of asking CRQs. It's called as a constructive review question or something like that, because I have not appeared in any exam with CRQs, but they are very, very good for understanding. Okay. So thank you very much. I will just stop here. Okay. So this is the books folder. And as I was telling you, basic sciences review books, clinical review books, MCQs books, SAQs books. Okay. And I have numbered them 1, 2, 3, 4, 5, 6 like that. And in the MCQs world, this basic sciences MCQ, best choice MCQs, and there are some certain pools you can get it from here. Okay. And this was the book I was showing you. For all the monitoring equipment, you can read this book. Okay. And there are a number of other books as well. All of them are alike actually. You can choose, maybe one topic will be written in one book in a better way, and other in the other way. Okay. This is for basic sciences. If you want to clear your basic sciences concept, this is a very good book. This is MasterPass is very good book. Okay. Okay. So, okay, bye-bye. Assalamu alaikum. I have, Dr. Shearing, I have shared the YouTube link 100 times. Unfortunately, it has not passed. You have not seen it. If you follow the things sent by me, you will find everything. I will send again. Okay. Thank you. Bye-bye.